क्लियर है सर, क्लियर है।
ठीक है. Clinical presentation of kidney and urinary tract. So, what do you think? First of all, the history taking. The medical history is the cornerstone of the evaluation of the urological patient. A complete history can be divided into the presenting complaint, history of presenting complaint, patient's past medical and surgical history, family history, along with the examination of the patient. So first of all, regarding the urology, we are specified to the urological symptoms, which are, it can be categorized into one or more of the following, like pain, low urinary tract symptoms and general urinary symptoms, hematuria, and incontinence. These are the four complaints mainly which can due to which patient comes to the urology OPD. And regarding pain, it is further categorized into when the patient come to the OPD with the complaint of pain, we ask the following questions to the patient, like site, where is the pain, or the maximal site of pain, where is the pain, like right flank pain, left flank pain, and is it in the hypogastric pain, and along with it onset, where did the pain starts and was it sudden or gradual, what is the character of the pain, like an ache or stabbing pain, radiation, does the pain radiate anywhere, like from loin to groin, or association, any other sign and symptoms associated with the pain, like nausea, vomiting, fever, and the time course, does the pain follow any pattern. Some patients complains that the pain is continuous or it occurs mostly in the morning or in the evening, and along with it exacerbating or relieving factors, what are the factors due to which the pain relieves or or the pain exacerbates. Like some patients complains that the pain get worse after lifting any heavy object, and it is relieved when the patient lies down or taking some kind of analgesics. And along with it, the severity, how bad is the pain, it is mild intensity, moderate, or severe intensity. And the mnemonic of this is SOCRATES: site, onset, character, radiation, association, time course, exacerbation, exacerbating or relieving factors, and severity. This is the mnemonic of the history of the pain. जी नवीन अजहर, नुमान साहब, नवीन अजहर का माइक ऑन कर देंगे.
सर मैं कर रहा
ओके,
हूँ।
नहीं नहीं, वो बाय मिस्टेक हो गया. ठीक है. नेक्स्ट टू द हिस्ट्री ऑफ पेन. When the patients come with the renal pain, how can we conclude that it is the renal pain? The site is right or left flank pain. Onset can be sudden or gradual. Character, in if there is acute obstruction, the pain is colicky in nature. Colicky pain radiates from loin to groin and to the testicle in the males and to the labium in females. And if it is due to the chronic obstruction like chronic stone, the pain could be dull and sometimes no pain. The pain radiation across the flank anteriorly towards the upper abdomen and umbilicus and maybe to the testis or labium. It is associated with gastrointestinal symptoms, like if the patient comes with the ureteric stone, the symptoms are the right flank pain, which will radiate from loin to groin, and it is associated with nausea, vomiting, or can be, if the stone is infective, it can cause fever. The nausea and vomiting is because of the reflex stimulation of a celiac ganglion. The time course is continuous, can be continuous or can be intermittent. It can be exacerbated by drinking plenty of water, and it can be relieved by analgesics. The severity depends upon the obstruction. If there is a severe obstruction, the pain will be severe. If there is a just stone falls in the ureter, it is in the early stage, the pain could be mild intensity. Ureteral pain. It is usually acute and secondary to obstruction. Distribution of the pain according to the site. If there is a upper ureteral obstruction or upper ureteric stone, the pain may be referred to the scrotum in the male or the labium in the female. If there is obstruction in the mid ureter on the right side is referred to the right lower quadrant at the McBurney's point and simulate appendicitis. It can be differentiated, it can be confused as an appendicitis, and if the pain is on the left side, to the lower quadrant, if there is obstruction on the left side. The lower ureteric obstruction or the lower ureteric stone causes bladder irritability, and the patient, along with the pain, also complains of frequency, urgency, and suprapubic discomfort. Vesical pain. Vesical pain is most likely due to the inflammation or infection in the urine or in the bladder. It can be due to the retention of urine or inflammation. There is an intermittent suprapubic discomfort and inflammatory conditions of the bladder or any infection in the bladder. There is a constant suprapubic pain that is unrelatable to the urinary retention is seldom of urologic origin. The constant suprapubic pain that is unrelated to the urinary retention is seldom of urologic origin. What it means? It means that if there is a constant suprapubic pain and there is no urinary retention, there is a chance that there is some other problem. If the female, it can be due to other pelvic inflammatory disease, or it can be due to constipation. There are many other reasons for the suprapubic pain if there is no retention or if there is no infection. Testicular pain. Acute testicular pain could be due to acute epidermolysis or orchitis or torsion of the testis. These are the two main conditions which causes acute testicular pain. Chronic scrotal pain, dull or heavy due to hydrocele or varicocele. These are the two conditions which causes chronic scrotal pain. Now coming to the second point, low indirect symptoms. First, we ask the patient regarding the pain. If the patient is having any pain, then we ask the symptoms. We ask the things which we have discussed earlier. Now coming to second point, if the patient is complaining of urinary symptoms, like the urinary tract symptoms is divided into the three things: storage symptoms, which includes frequency, nocturia, urgency, urgent continence. Voiding symptoms are divided into flow or stream, straining, intermittency, hesitancy. Post-micturating symptoms include sense of incomplete voiding and dribbling. Now we will further elaborate what is frequency, nocturia, urgency, urgent continence, and the voiding symptoms. In the storage symptoms, what is frequency? Frequency is passing urine more often than usual without increase in the amount of urine. It is either due to the incomplete bladder emptying or decreased bladder capacity. Normal bladder capacity is around 500 ml. If there is a small bladder capacity, the patient will go frequently to the washroom. Or if there is incomplete bladder emptying, like the patient goes to the washroom and passes only if the urine is in the bladder is around 400 ml and the patient only void 100 ml, that 300 ml was left, so the patient will go again early. So this is called frequency. What is nocturia? Nocturia is nocturnal frequency. Normally adult sorry adult rise no more than twice at night to void. This is decreased urinary concentration with age. But in nocturia, nocturia means the patient can go to the washroom more than twice, more than 2 times. If the patient is going to the washroom, this is called nocturia. Nocturia occurs in patients with congestive heart failure and peripheral edema, and also in diabetic patients. If the patient is having increased sugar levels, the patient is having complaint of nocturia. What is urgency? Urgency is the sudden intense desire to void that the patient cannot defer. It occurs in patients with urinary tract infection or detrusor overactivity. Sorry. Now coming to the urgent incontinence, this is a loss of urine preceded by a strong urge to void. It can be due to cystitis or weak sphincter mechanism. What do you mean by weak sphincter mechanism? There is an external urethral sphincter, internal urethral sphincter. If the sphincter is weak, the patient will complain of urgent incontinence. Voiding symptoms. Voiding symptoms include hesitancy. It means delayed in the start of urination. The patient will tell you that there is a delay in starting of urine. Decreased force and caliber of urinary stream. It is due to the bladder outlet obstruction and commonly results from benign prostatic hyperplasia or urethral stricture in males. If the prostate becomes enlarged, the stream becomes weak, or if the patient is having a urethral stricture, the stream becomes weak. Straining. The patient will complain you that he has to strain or she has to strain while voiding. It refers to the use of abdominal musculature to urinate. What is intermittency? Intermittency means interrupted stream. The patient will tell you that the stream is intermittent. This is not a continuous stream, the stream is intermittent. Now, the post-micture symptoms include sense of incomplete voiding. This sentence already clears that the patient will complain that he cannot completely void or cannot completely empty his bladder. He is having sense of incomplete voiding. And the post-void dribbling refers to the release of few drops of urine after micturition. These are the symptoms of urinary symptoms, lower urinary tract symptoms, which is also called as LUTS. This is the mnemonic, which is fun, frequency, urgency, nocturia. This mnemonic relates to the storage symptoms. If you want to remember this, this is the mnemonic. Now, coming to the general urological symptoms, which includes anuria, negligible amount of urinary output. You have, if the patient is complaining of anuria, you have to rule out the cause. Is it the urological cause or is it a nephrological cause? Urological cause means if there is some kind of obstruction like bilateral ureteric stones, bilateral ureteric strictures, bladder outlet obstruction, which can be due to prostate, can be due to the stricture, can be due to UTI, which causes anuria. And if it is a nephrological cause, there is some sort of renal failure like acute kidney injury, acute renal failure, which causes anuria. Now, coming to the oliguria, oliguria means less than 400 ml per day or 0.5 ml per kg per day in adults. Oliguria can be due to acute renal failure, dehydration, and cardiac failure. Now, coming to the polyuria, polyuria means increased amount of urinary output over 3 liters or 3000 ml per day. Causes include diabetes mellitus and diabetes insipidus. Now, coming to the next topic, incontinence. Incontinence means urinary incontinence is the involuntary loss of urine. The further subtypes are continuous incontinence, stress incontinence, urgent incontinence, overflow incontinence, and enuresis. Continuous incontinence means most commonly continuous incontinence means there is a continuous loss of urine. And what are the causes? It can be due to urinary tract fistula, like vesicovaginal fistula due to gynecological surgery and radiation or obstructed trauma, which can lead to continuous incontinence. And what is the stress incontinence? Stress incontinence, sudden leakage of urine with coughing, sneezing, exercise, or some stress, which due to increased intra-abdominal pressure. It is most common in women after childbearing or menopause and men after prostatic surgery and injury to the external urethral sphincter. Urgent incontinence. The loss of urine preceded by a strong urge to void. It is due to cystitis and overactive bladder. Now, coming to the overflow in incontinence. Overflow means the bladder is completely filled. Now it is dribbling. It is due to the advanced urinary retention and high residual urine volumes. Urine dribbles due to bladder overflow. The bladder is completely filled. Now it is overflowing. Enuresis. Enuresis mictures that occur during sleep. It occurs normally in children up to the 3 years old. After the 3 years, the adult or the child become conscious that he or she should not be voiding during sleeping. So this is a normal phenomena, but some patients come with the complaint of nocturnal enuresis at the age of 7, 10, 15. The enuresis will continuous. Now, coming to the next topic, hematuria. What do you mean by hematuria? It's the presence of blood in the urine greater than 3 RBCs per high power field microscope. In evaluating hematuria, we first have to ask the patient it is a painful or painless. It is a gross or he has some type of reports which is giving the report that is a microscopic hematuria. And we also have to ask the patient about is it initial at the beginning of micturation, is it terminal at the end of micturation, or pan hematuria like patient is not passing urine, he is only passing blood in his urine all through the urine. Or we have to also ask about the is it associated with any clots or not, and if he or she is passing clots, so what type of clots, like linear clots or amorphous clots. If the patient is saying that he is passing amorphous clots, so we will think about the blood is coming from the bladder. And if he is saying there is a linear clots, there are more chances that the clots, and there are the bleeding in the kidney or in the ureter. So the clots will shape in the line. In the linear clots means the clots are coming from the upper tract like kidney or ureter. What are the causes of hematuria? Painless hematuria. If the patient is complaining that he's a painless hematuria, so what things we will think about? We will think that if there is a chance of tuberculosis, due to tuberculosis the hematuria could be painless. If the patient is having urogenital tumors like kidney tumor, ureteric tumor, or bladder tumor, prostatic tumor, it will cause painless hematuria. Glomerulonephritis can cause painless hematuria. Renal cystic disease can cause painless hematuria. If the patient says that he's having a painful hematuria, then we will think about calculi stone, renal stone, ureteric stone, or bladder stone, and UTI. UTI also causes painful hematuria. Now coming to the second part of clinical presentation, at first we have discussed about the symptoms. In symptoms we have discussed about the pain, then coming to the urinary symptoms, then incontinence, general urological symptoms, then hematuria. After having history, then we will come to the examination. Examination includes the kidney examination, bladder examination, and prostate examination. For kidney examination, we have to palpate bimanually for the kidney. If there is a tenderness over the kidney, should be tested by general pressure over the renal angle. Bimanual examination for renal enlargement or masses by with a hand posteriorly lifting up the kidney towards the examining abdominally placed hands. You can see the left hand is pulling the kidney towards upside, and the right hand is palpating the kidney for any mass. And for the bladder palpation, we can examine the hypogastrium. The bladder is palpable if there is a urinary retention. Bladder can only be palpated if there is a urinary retention and the bladder becomes palpable. If the patient is having complaint of scrotal pain, testicular pain, then the examination of his scrotum can be done. Inspect the scrotal skin, palpate the testis, again, it is painful or painless. Palpate the epidermis and vas. Identify scrotal swelling if there is any scrotal or inguinal scrotal swelling. And if the patient is having inguinal scrotal swelling, okay, so we have to check, is it possible to get above the swelling? Is the swelling solid or cystic? Is there is a hydrocele, varicocele, or epidermal cyst? How can we differentiate hydrocele, varicocele, and epidermal cyst? Varicocele can be seen like bag of worms. If you can examine you can feel the varicocele. And hydrocele and epidermal cyst, we have to test for translucency with a torch, will determine whether the mass is cystic or solid. Hydrocele epidermal cyst, with there is a translucency test is positive. It means that the light can pass through. But in solid like testicular tumor, non-translucent, the light will not pass. In cystic, translucent and positive like hydrocele epidermal cyst. And how can we differentiate hydrocele and epidermal cyst? Hydrocele is a like cystic swelling along with the testis. We cannot separately palpate the testis along with the hydrocele. But in epidermal cyst, we can feel the testis and the cyst separately. Now coming to the rectal examination. Rectal examination is performed to palpate the prostate gland and a canal to assess prostatic size, prostate consistency, prostate median sulcus, prostatic tenderness, anal tone, anal pathology. A hard area in either or both lobes suggests a cancer and biopsy is needed to obtain a histological diagnosis. This is the things which we have to examine in digital rectal examination: prostate size, prostate consistency, it is soft, firm, or hard in consistency. Prostate median sulcus is palpable or not. If the prostate is large, we cannot palpate the median sulcus. Prostatic tenderness, if the tenderness is positive, it means there is a prostatic abscess, and if there is no tenderness, means there is only a benign enlargement. Anal tone, the anal tone is present or not, and if there is anal pathology. Thank you. This is the lecture. If someone has to ask any question, please ask.
सर लेक्चर आपका एंड हो गया?
जी लेक्चर एंड हो गया. आप कोई क्वेश्चंस वगैरह किसी ने पूछने हैं तो
सर आप मैसेज करेंगे सारे कैंडिडेट्स?
मैसेज कर दूं? हाँ मैसेज कर रहा हूँ.